All right, let's talk about one of the most dramatic and time-critical emergencies you'll ever face in anesthesiology, aortic dissection. Nailing the diagnosis and management and doing it fast is absolutely everything. Okay, let's dive into this essential topic for your finals.
And when we say time critical, we are not kidding. See this number? 1 to 2%? That's the increase in mortality per hour for an untreated ascending aortic dissection. The clock is literally ticking from the second the symptoms start.
So, here's our game plan for this explainer. We're going to start with the basics, what's actually happening inside that aorta. Then we'll get into how we classify these tears, which is the key to everything that follows. From there, we'll build the clinical picture, figure out how to lock in the diagnosis, and outline the emergency management plan. And finally, we'll focus on the part that matters most to us, the anesthetist playbook in the operating room.
All right, first things first, let's establish a really solid foundation. What exactly is an aortic dissection?
At its core, it's all about a tear. Blood finds a weak spot, a little rip in the inner lining of the aorta. That's the intima. And it doesn't just leak, it surges through. It starts plowing its way right into the middle layer, the media, literally splitting it apart. This carves out a brand new and very dangerous channel for blood, the false lumen, right inside the aortic wall itself.
So you might be asking, how does this even happen? Well, it's rarely a healthy aorta that just gives up. Usually there's some underlying weakness, a condition we call medial degeneration. And the two biggest culprits pushing that weak wall to its limit? You guessed it, chronic high blood pressure and an already dilated aorta. That constant stress is just too much, and the tears tend to happen in two classic high-pressure spots, right above the aortic valve and in the descending aorta just past where the left subclavian artery branches off. Okay, so we know what it is. Now, it's absolutely crucial to understand that not all dissections are created equal, and how we classify them, it changes everything. You know, with modern imaging, we've realized this is more of a spectrum of injuries, from hematomas inside the wall to plaque ruptures, and the European Society of Cardiology has this really comprehensive classification for all of them. But for what you need to know day to day, and especially for your exams, it's the simpler anatomical classifications that are pure gold. And here are the two big ones you need to know. Now, DeBakey's classification gives you more anatomical detail, which is great, but honestly, the Stanford classification is the one you'll see used most often, and for a very good reason. It's beautiful simplicity. It boils everything down to one single critical question. Is the ascending aorta involved? If yes, it's a type A. If no, it's a type B. And that one distinction, right there, is the most important fork in the road for deciding what to do next.
Okay, let's switch gears and focus on the patient. How does this present? What are those classic red flags that should be screaming aortic dissection in your head?
The textbook case, the one you always hear about, is that sudden, incredibly intense chest pain. Patients often describe it as tearing or ripping. That's the buzzword. And the pain isn't always static. It can actually move or migrate as that tear continues down the aorta. You'll also want to check for a pulse difference between the arms. A new diastolic murmur could mean the aortic valve is now leaking. And this is a big one. If the dissection messes with the blood supply to the brain, you can get some really scary neurological signs, like passing out or even having a full-blown stroke.
So, who's our typical patient? Well, often it's an older man with a long history of hypertension, but you've got to keep your guard up. Always think about dissection in patients with known connective tissue problems, like Marfan syndrome, or folks with structural heart issues, like a bicuspid aortic valve. These conditions just make that aortic wall inherently weaker and more prone to tearing.
All right, you've got a strong suspicion. Now you have to prove it, and this is truly a race against time to get that definitive image.
This is the million-dollar question in the emergency department. The chest pain can look and feel exactly like a massive heart attack. So an immediate ECG is an absolute must. Why? Because the treatment for an MI, thrombolytics, blood thinners, would be an absolute disaster, literally fatal, for a patient with an aortic dissection. And here's the tricky part. About 20% of type A dissections can cause ECG changes if a coronary artery gets pinched by the dissection flap. So even if you see something on the ECG, you have to get that scan before rushing them off to the cath lab.
So when we rush that patient for a CT scan or an echo, what exactly are we trying to find out? Well, we have four main goals. First, obviously, confirm the diagnosis. We need to see that intimal flap. Second, we have to classify it. Is it a type A or a type B? Third, we need to map it out. Which major arteries are involved? The carotids, the renals, and finally, we're hunting for any immediate, life-threatening complications, like a leaky aortic valve or blood in the sac around the heart, which could lead to tamponade.
Okay, the scan is back. You've confirmed it, you've classified it, now the path forward becomes crystal clear.
And this slide, right here, is probably one of the most important takeaways for your exams. It's so simple but so critical. Stanford type A, meaning it involves the ascending aorta, is a surgical emergency. Full stop. The risk of the aorta rupturing into the pericardium or the patient having a massive heart attack is just way too high to wait. On the other hand, type B dissections, where the ascending aorta is spared, are usually managed medically, at least at first. We hit them hard with medications to control heart rate and blood pressure. Surgery is only on the table if things get complicated.
So what does medical management actually mean? Well, first off, we've got to get their pain under control with strong opioids like morphine. Then it's all about hemodynamics. And here it is, a classic exam question. The order of the drugs you give is absolutely critical. You must give beta blockers first. This brings down the heart rate and the force of each contraction. Only after you've got that heart rate controlled, if the blood pressure is still too high, do you add a vasodilator. If you do it the other way around, the reflex tachycardia will actually increase the stress on the aorta and can make the dissection even worse.
All right, let's fast forward. The call's been made, it's a type A dissection, and the patient is on their way to the OR. This is your moment. This is where your specialized skills as an anesthetist are front and center.
Okay, getting set up is absolutely key. You need large-bore IVs ready for a potential massive transfusion. For your arterial line, the rule of thumb is to place it in the left radial artery. Why the left? Because the dissection can easily compromise the innominate artery, which feeds the right arm, making a right-sided line totally unreliable. And intraoperatively, your best friend is the transesophageal echo, or TOE. It is invaluable for confirming everything one last time and helping to guide the surgeon's every move. Now, getting the patient on the heart-lung machine is tricky. The usual places we'd put the cannulas might be right in the middle of the dissected area. But the real challenge often comes when the surgeon has to repair the aortic arch. To do that safely, they often have to stop all blood flow in the body for a period of time. This is a state called deep hypothermic circulatory arrest, or DHCA. So when the circulation is stopped during DHCA, your number one job becomes protecting the brain. The main strategy here is deep hypothermia. We cool the patient way down, sometimes to as low as 18 degrees Celsius. This slows the brain's metabolism to a crawl. Surgeons might also use special techniques to pump blood directly to the brain. And as the anesthetist, you'll be giving adjunct medications like steroids or thiopental and making sure the patient's head is packed in ice, all in the name of neuroprotection.
So, to bring this all home, this quote really sums it up perfectly. Survival in aortic dissection depends on a flawless chain of events. It starts with having a high index of suspicion. Then it's about a super fast, accurate diagnosis, getting that blood pressure and heart rate under control immediately, and for every single type A dissection, getting that patient into the operating room as fast as humanly possible.
Now, everything we've gone over in this explainer is drawn from this fantastic review article in BJA Education. It's a really high-yield read. We've hit all the major highlights, but I definitely recommend you go check out the full paper as part of your exam prep. I really hope this has helped you get a solid grasp on this critical topic. Thanks for listening.